Hello everyone, welcome back. This is Health Economics. Starting chapter 16, we are going to mainly focus on the three healthcare models that we study in different parts of the world. So the first one we are going to study is the Beveridge models that actually originate from UK. So in this chapter, we are going to first talk about the models, what are the objectives, what are the goals to achieve, and also how the system look like. And then we will talk about how the system have some problem or issue by itself, such as without the pricing rationings, the moral hazard with causing overuse of the healthcare system in the, under the public provisions. So waiting time will be long. Well, how are we going to optimize the time wait for patients? And also, what are the other tools that we can use to improve the service quality within the public system? And then for the next two chapters, we are going to discuss about the other two models that we started in chapter 15. Well, a little history about the Beveridge plans or Beveridge healthcare system. In the late 1940s, after the World War II ended, well, the UK and much of the rest of the European country, they were just starting to recover from the war of World War II. The soldiers were returning from the front lines, and also the economies in those countries were just rebuilding and restoring its economic strength. Well, one of the main problems that most of the country face, including the UK, is with all these soldiers returning, and also people were just trying to recover from the war and trying to get a job. Well, it's very difficult to handle all these people who might actually suffer from the war of different kinds of injuries or illnesses. So the UK actually came up with this proposal or new bills, which was introduced in 1946. It's called the National Health Service Bill. The bill was actually formed by many economists, and one of the leaders of this proposal, his name is William Beveridge. So William Beveridge actually has these provisions to have this healthcare system set up in the UK, which will provide very, very high level of equities of access for the populations or citizens in UK, and by having the governments taking over the healthcare system. So the Beveridge model basically is named after this great economist in the UK. There are three main features in this model. Number one, the universal or single payer insurance. Number two, the public health care provisions. And number three, the fee care. So the universal or single payer insurance basically is insurance coverage that offered by the government. And we call this sometimes a single payer insurance because, well, this insurance coverage will be offered by only one payer, which is the government. And usually those insurance coverage is funded by the tax money. And the public healthcare provisions basically it's the provisions that have the governments to fully fund the main hospital facilities or clinics in the country. So under this public health provisions, well, most of the hospitals and clinics or maybe healthcare providers are basically either owned by the run by the governments or hired by the governments. And also, free care is the main features of this beverage models. So free care means people will have free access to any of the government-run hospitals, and people will not have to pay anything upfront or either after the service. However, even under the beverage model, there are some exceptions for some of the healthcare services or medical care services. For example, in the UK, prescriptions of drugs, eye care, or dentistries, well, those are the services that is exempt from the free care features. So the ultimate goal to achieve for the UK government under this beverage system is to have the government provide the healthcare services and fund by the tax revenues. So we are basically just making healthcare available for everyone, and just like all the other public services that we expect the governments to take over, like the public school system, the libraries, or the parks. The kind of goods or service with these properties basically are known as the merit goods. So the merit goods are something that we expect the governments to provide. And in most of the developed nations, actually healthcare considered to be a merit goods. So for example, there exists a public insurance program to provide care for elderly in every developed nations. Such as the US, we have the Medicare, which provide a universal insurance for the elderly over age of 65. But the beverage model actually goes further. So the beverage model actually organized the health policy around the idea that all citizens should have equal access to the health care, regardless of their personal wealth. So in these models, the allocations of healthcare, it's only based on the needs, but not the ability to pay for the service or the good. Well, by doing that, the main key to this model is to take out the price rationings in the markets. So price is not something that people will consider when they try to get access to the service, but to maximize or to promote equity to the populations. So equal access is the main objective to achieve in these types of model. Before we start our discussions on the beverage system, we are going to take a very quick tour of the beverage world and see how the system is adopted by different nations in the world. So since 1948, after the adoptions of UK, there are other countries in the world also trying to adopt this healthcare system in order to improve the equities of healthcare services in the nations. So countries like Canada, Australia, Sweden, Norway, they all are the big developed country that adopt into the beverage healthcare system. Well, they are basically diverse in many different ways, but they tend to divert for two major objectives. So number one depends on how the country think about allowing competitions within the healthcare market. And number two, how the country will decide on trying to contain the total healthcare expenditures within the country. As comparing to the UK, well, the Canadians' healthcare system actually provide this paralleled healthcare system where the private firms and the public agency can run the healthcare services at the same time in the country. And as comparing to other beverage worlds or beverage system country, the Canadian hospitals are majority run by the private firms instead of the government-funded public hospitals. Well, allowing private firms to run the majority of the healthcare markets has an advantage to increase the level of competitions in order to have the quality of services to increase. Well, when we look at the Sweden's situations, well, also they allowed both the private and the publics to run the healthcare services within the country. However, majority of the service still provided by the public hospitals. However, the Sweden's healthcare system actually contained this very interesting factors in the public insurance policy, which is the cost sharing requirement. So the patients basically who wants to get access to the healthcare system, now they are basically facing this or require for sharing some of the cost with the government. So for example, there is an annual deductible for participation's medications of about $250 a year in Sweden. And also there will be a small co-payment for doctor visits or hospitalizations. But the annual deductible, it's very, very low. And usually those services has a deductible of about $100 annually. So it's a minimum cost that the patient has to pay in order to get access to the services. But because of the cost sharing nature, it actually helps contain the moral hazard behavior. On the other hand, the Australia government actually provide this very special paralleled healthcare services. So the Australian patient, they can receive free care from the public hospitals, and the program under the public agents, it's basically the same, share the same name as the US. It's called the Medicare. So they can basically just get a free service at the hospitals because all these goods and services are funded or financed with the taxpayer funds. But also the patients who are admitted to the hospital, they actually have a choice to choose whether to be treated by the Medicare, which is free, or by the private doctors for a fee. And sometimes the patient will choose to pay a fee to actually escape those long cures. So the waiting time can be resolved for those patients who really in need of the services. So every country has its own features adding on to the system. Well, there are different objectives each country they are trying to achieve, but there are also two fundamental questions that every healthcare system face, and especially important to answer under the beverage system. So the question to ask should be, well, how much healthcare should be produced in the nations? And also, who should get it? Well, in the private markets, well, those two questions can be answered under the supply and demand models. But unfortunately, under the beverage system, the price rationing is actually taking out of the markets. There is no price mechanism because, well, no one have to pay. So scarce resources within the society, they will still have to be determined how the goods and how many of the goods should be produced. Well, what's the level of healthcare products or healthcare services we should actually provide. And without the price rationing, it becomes very, very difficult to actually answer those two questions. So if not the price rationing, then what? Obviously, when healthcare is free under the beverage system, there must be some other way to determine who should get the service and who should actually get the healthcare. Well, some of the strategies include queuing, gatekeeping, and limiting the coverage through health technology assessment. So cure basically is the main problems that we usually see in the beverage world. Almost all the beverage healthcare system suffer or maybe have a problems to solve for long waiting time at the hospital. Well, first of all, we would like to actually understand why the cure exists. Well, because of the beverage government's mandate free care to the public. Well, it's very, very easy for the moral hazards behavior to actually increase or rise the demand for healthcare services in the markets. Well, in the private markets, physicians and nurses' salary actually increase so that the supplies match with the demand. But under the beverage system, well, the salary basically set by the government. So in general, the markets cannot collaborate. Well, the high demand and low supply will usually result in cures, and that's in generally what we see under those beverage healthcare system. Well, here are some of the evidence suggesting that the long cures actually happens in most of the beverage system. Well, a survey in 1990 actually found that the median wait time for English patients for the inpatient service was about 5 months. So that means it takes 5 months time in order for allows the patients to get the inpatient service in the UK. Over 20% of the patients had waiting time for longer than a year, which is a study illustrates um, by the Department of Health in UK in 2011. Well, in 2001, another survey also revealed that the 38% of the patients in the UK, 27% in Canada, and 23% in Australia has been waiting more than 4 months for the treatments. And in another survey of 2010, the median waiting time for Canadian patients was over 2 months. Well, this long waiting times for getting the service actually makes patients very angry, or sometimes will have a very, very strong political flashback. And many reforms since then focus on reducing a long waiting time at the hospitals. Well, most of the time, the cures are usually perceived negatively, but they may actually serve some desirable social purpose on its way to the system. So, for example, the long waiting time actually might deter people who don't actually need the costly procedures. By providing these long cures, it actually allow people to give up this free service. Since the service itself is free, well, now the long waiting times becomes a cost for people to decide whether they would like to get the service on their own. People who needs to wait several months or even years, well, now they might be hesitate to get those procedure done if they don't really need it. So it actually serves as a means of limiting the moral hazards in the healthcare markets. For example, a mail survey of 757 people on waiting lists for orthopedic surgery at a large British general hospital actually revealed that 17% no longer wanted the surgery, while 9% have moved away and 5% had died. Another 9% had already received treatments. Only 48% of the people on the wait list still actually want the treatments. So this is the evidence of rationing power of long waiting time. And what's more, if the patients who drop out of the quilts were one of whom the surgery was not that valuable in the first place. So the long cure actually saved money without sacrificing much of the patient's health in this case. So unlike the price rationings, the cures actually treats both the rich and poor equally. So it served the purpose for under the provisions of beverage system to provide or to promote equities to the society. So in order to study the problems of cures at the hospital, we would like to use this one very simple model to actually illustrate the problems here. Let's suppose we have one hospital's orthopedics department which has a long waiting list for knee replacements. And right now the cure has 8 patients waiting to be seen by the single orthopedic surgeons on staff. Well, the patients in the waiting list are defined in 2 ways. The U patient basically are the ones who can utilize the surgery and get most of the benefits. So that means the surgery actually benefits or very, very useful to the patient solving their health problems. On the other hand, we have the W patients, which is the patients whom the surgery won't be that beneficial or that useful to them. They might actually feel some discomforts from their needs, but replacing the needs is not going to help them that much. So it only provides a very marginally benefits to them. And also we defines UP here, which are the patients who actually benefits the most from the surgery, but at the same time, they are considered to be the poor patients. And if any fee it's asked from this patient, they won't be able to afford it. So they will just have to give up. So by looking at the quotes here, well, obviously, this is a first come, first serve system. If people get in line first, well, they will be getting the service first. And it creates a problems. Well, first of all, as you can see, if there is a patient that considered to be W patients, which have a very low benefits from the treatments, if they are actually getting in line before those who actually can get most out of the surgeries, which is the U patients, well, then that means, well, the service will get to those low benefits patients before the high benefits one. Well, the inefficiency arises because the care is free for everyone. So the W patients do not internalize the cost of care. So just join the cures anyways, and they will ultimately get the service. And sometime, in most cases, they will get in front of many patients who will get most of the benefits from the treatments. So one way to solve this problem is basically by adding the price rationing into the service. So let's suppose instead of having the patients to get the service for free, and now the government actually asking people to pay some amount of out-pocket fee for the treatments. And we assume those out-of-pocket fee is high enough to drive the low benefits patient, which is the W patients, away. And this actually reduced the curing problem because, well, the W patients will never sign up for that treatment because it's not free anymore. However, by adding this price rationing into the public hospital, it actually creates another problem because now those people who actually are poor and cannot afford for those out-of-pocket fees will not be able to get the service or not be able to get access to the service.
So now it backs to the problems because well, the provisions of beverage system is to provide equity. And now adding the price rationing into the public health system, it actually not only uh, limiting the moral hazards for overuse from the low benefits patient, but also at the same time, it limits the access for those who have lower income. So the equity problem becomes a major concern under those pricing rationing policy. If price rationing cannot solve the problems without sacrificing the high benefits, poor and low income patients, well then other rationing has to apply in order to adjust for those long cures in the beverage system. In most beverage system or countries, well, all the patients must actually first visit someone that we call the general practitioner, the GP, before they can get access to the specialist. Well, the GP in this case basically is what we call the gatekeeper. So gatekeeper basically is the third agent in the system to provide professional advice for the patients to see the specialists in the healthcare market. So without these recommendations from the general practitioners, patients in general, they cannot get the special service that they actually want. So in this case, if the gatekeeper is doing a good job, so the only patients that they can actually get the benefits from the surgery or the treatments are the ones who really in need of the service. Let's suppose if we assume the gatekeepers are very, very effective, well then the cures will look something like this one. So all the patients left in the cures are basically those who will in need of the service the most and will be benefits by the service or the treatments the most. However, if applying the gatekeeper, still we see a very, very long cures in the healthcare system. Well, it actually signifies that it's insufficient to provide delivering the valuable medical care in the country. So there might be someone out there who really in need of the service or the treatments, but they actually are forced to keep waiting in the society because we just don't have enough surgeons or maybe service provider in the market. It potentially actually involved with a very, very huge social loss from this kind of long cures. Well, in order to estimate the social welfare, well, there are several strategies that can be applied. If we really want to actually capture or calculate the social welfare loss from the cures as presented in the previous slides, well, there are three main strategies that has been introduced for estimations. Well, number one, we can actually ask the patients hypothetical questions about how much they will be willing to pay to receive the care now as comparing to if they have to wait in line. And number two, to calculate the social welfare loss from patients' willingness to pay extra for the private care. So instead of getting the free public care to wait in line, well, how much they are willing to pay for the private care right now to get the service. And number three, we can also estimate the welfare loss from patient willingness to travel to how far or the distance from the living location to a different location to receive a quicker care. Well, regardless how we want to estimate, there will be some kind of estimation to tell us about how much people are willing to pay more in order to get that service now. That's what we are trying to estimate at the end. Well, all three methods actually give us a very similar result. For the non-urgent procedures, a month of reductions in waiting time, it's only worth around $200. So that means people who actually want to reduce a month of waiting time for the non-urgent procedures, they are only maximally willing to pay 200 max on average in order to get the service right now. So this low estimate actually remains a puzzle comparing to attention long waiting times received. So there are some policy actually suggested by the government in order to reduce the cures. So reduce curing, well, either to decrease the demands or maybe by increasing the supply. So let's take a look at this idea. So one way to effectively decrease demand is to increase the use of gatekeeper, as we illustrated earlier. Well, by limiting the access of low benefits patients, we can definitely reduce the demands of the service. Well, another way to reduce demands or decrease demand is to set a stricter eligibilities thresholds for the care. So to set a much stricter rule for getting access to the service, so that it will only allow people with certain criteria in order to get the service. And also to prioritizing the patients, so not just the first come first serve, but there may be other ways to prioritize the service to different types of patients or different needs of the patients. Well, on the supply side, we can actually increase the supply by hiring more doctors or building more hospitals. Well, in the long runs, well, setting a higher salary for medical staff may actually induce people to enter the job markets or the healthcare service labor markets. And that will also increase the supply because the number of service provider will increase in theories. Or maybe the third way to increase supply is to outsource the care to private providers, to let the private providers to provide the care for the public system. Right? So in the reverse, basically, we can actually pay the money to the private providers in order to provide those services to the patient directly. So subsidize or subsidies usually is one way to do it. Well, each of those strategies actually come with its own cost. So there will always be a trade-off between equity, health, and wealth. So for example, by having the gatekeepers screening the patients before they seeing the specialist, it might actually limit some of the people who might need the service or may need the treatments to see the specialist. So now it creates the equity problems within the society. Or sometime when we are actually increasing the level of supplies by building more hospitals or more hiring more doctors, well, in generally we are devoting a lot of the resources in this case towards healthcare services. So the government might actually run the healthcare system with a higher cost and not be able to generate enough money to fund other projects. So the wealth of the nations may be affected in this case. So typically the governments in the world, they are trying to adopt a combination of these tactics or strategies in order to um, uh, achieve their goal to either reduce the total expenditures, to shorten the waiting times, or maybe to provide equity to the healthcare system. Taking an example in the UK, they have been successfully reducing the waiting times in the year of 1990s since they set this waiting time targets. However, taking a look of Canada, well, almost every province in Canada between the year of 1993 and 2010, they failed to adjust for those long waiting times patients. So some of the strategies they apply does not actually effectively shorten the cures or long waiting times for the patients in the country. Well, in the next sections, we are going to discuss how the health technology assessments actually helps the governments to contain the total healthcare expenditure within the country. Well, as we mentioned earlier, the moral hazards becomes a very serious problem in the beverage system because there is basically just a free service that everyone can get access, and it's very easily that we have the overuse of these services. So how much and what kind of service should the government provide to the patients? Well, the health technology assessment helps to contain the total cost of healthcare within the country because it provides solutions or provide a suggestion to the public agency to determine what kind of services they should cover and what should not.
So before 1980s, there is no formal or standardized analysis to determine whether a drug or a treatment should be denied to cover in the public health insurance coverage. And decisions to deny the coverage for expensive and ineffective care becomes very inconsistent because the fact that there's no one standard, there's no formal standardized way to determine whether the drug or treatment should be covered by the public insurance. Nowadays, well, we have switched to a lot of different techniques, including the one that we discussed in the previous chapters, which is the cost effectiveness analysis and also the cost and benefits analysis. Well, of course, making a decisions to either cover certain treatments or to deny certain treatments in the country from the public health insurance coverage can be very complex because it's not only taking into account for the cost effectiveness of the drugs or treatments, but also there are other criteria like the number of patients being affected by the treatments or drugs, and the clinical safety of the treatments, and any public health impacts on the drugs or treatments. This complex procedure taken by the governments, usually it's what we call the health technology assessments. So it helps distinguish whether the drugs should be covered by the public health insurance based on several factors, as we mentioned. The CEA and the HTA, they are not unique to the beverage countries. Both the public and private insurance plans in other countries routinely make similar coverage decisions as new technologies introduced to the markets. But the HTA takes a larger policy relevance in the beverage countries because the governments, they are the ones who pay majority of the healthcare expenditures in the country. And also, under the beverage system, well, the governments runs most of the hospitals and clinics, and they are the largest healthcare service provider in the country to deliver those services to the public. So that's why by having the HTA to determine whether the service or treatment it's worth for cover makes up a very important part of this beverage system. Well, sometimes the HTA decisions can be very controversial because the fact that once the drug is being denied basically means, well, people will have no access to the drugs or covered by the public insurance. So those drugs may not be accessible or may be available for the domestic patients. They may actually end up have to get the procedures or the treatments done somewhere else outside the country. So that makes it very, very controversial because it could be a life-saving treatment, but rejected by the government. Well, the HDA agents are diverse in different ways in different countries. Some country may have agents that play merely advising rules, where they actually giving some non-binding suggestion to the governments, and the government's agents basically just take it as a advisories. Versus there might be other country has the HTA agents that has the power to deny coverage for new drugs or other technologies in healthcare. For example, in 1999, the UK National Health Service actually established the National Institute for Health and Clinical Excellence, and we shorten it as NICE. So NICE was created with the authority to provide guidance on the use of new technologies and drugs. The institution also assessed only those technology likely to have a large budgetary impact. So the local authority decisions making whether one drug should be used or whether the hospitals or doctor are allowed to provide those procedures to the public depends on the decisions of NICE. If the procedure is approved by NICE, well, then the hospitals or the doctor can prescribe it. However, on the other hand, if NICE actually reject this new procedure or new drugs to be covered, then the doctors and the hospital cannot provide those procedure or drugs to their patients. On the other hand, well, there are other countries, the HTA agents only have the power to provide non-binding recommendations to the local health authorities, such as taking the case of Canada. So the Canadian Agency for Drugs and Technology in Health, which we call it the CAT, played a rule that they are going to, they usually provide non-binding recommendations to the local agencies or the local private hospital provider. And those advice or recommendations are usually very well respected by the local decision makers. So to sum this up, well, the HTA agency can be somehow controversial. It's very difficult to say the HTA agency are making the best recommendations to determine whether the drug should be covered or not. Well, in some extreme case, taking the examples in the United States, the US Medicare is one of the world's largest public insurance plan by its expenditures. It's also forbidden by law from denying any coverage based on the CEA criteria. Because it's controversial, because it's just so not easy to make those decisions by just one agency, well, it's very difficult to say, well, having the HTA is the only solution to help contain the healthcare costs or to eliminate the overuse of new technologies. Well, in the next sections, we are going to talk about how competitions might actually help improving the healthcare service in the country. Solving problems like the long queues for healthcare services under the beverage healthcare system remains to be the most difficult and challenging goals to achieve. Some of the country, they are actually trying to experiment putting in the elements of competitions into the healthcare markets in order to facilitate or to improve the quality of the healthcare services by shortening the waiting time for patients. Comparing to the competitive and privatized system, such as the US or other healthcare system or healthcare models, well, the competitive natures of the markets actually helps to resolve the problem of long cure, and it's rarely seen under those competitive settings. While nations, they are trying to experiment on these different provisions of healthcare, well, still the reforms that was introduced into the country is still trying to maintain the solidarity goal of the beverage model. So in general, injecting the competitions into the beverage healthcare system might actually cause other problems. And that's the reason why the beverage countries, they still have concern about putting a parallel system where the privates and the public hospital, they can compete with each other under the same provisions. Well, one problem arises is undermining the idea of equal access to care. Imagine with the parallel system, the rich, in general, they might actually have more opportunity to get to the service first by going through the private markets. Well, because they can afford it, they can actually pay a higher price for the healthcare. As comparing to the poor, they might actually stuck with the public system because they cannot afford it. It actually brings up the issues and also against the beverage idea of equal access. Well, furthermore, not only the patients will get unequal treatments or unequal access to care, but it also might actually affect the quality of care because the private sector actually pay better in general. The private hospitals usually run with an incentive to attract more patients with a higher quality of care. And those are the hospitals willing to pay a higher wages to attract better doctors, better nurses, and better service providers to actually provide those high quality of care to the patients. So if that's the case, well, the better doctors or higher quality staff might actually leave the public sectors and further undermine the solidarity's goals of the beverage models. Well, despite the worriness with the private markets or the parallel market system, the benefits of the competition are still very enticing, especially when the waiting time are very long. For instance, the long waiting time in the UK actually motivates a major reform in 1991. So before 1991, actually the UK hospital received an annual budget from the government. So basically it's a government-funded programs. So all the hospitals, they receive a fixed budget from the government every single year. And each year, the budget actually determines from the last year cost adjust for the growth of the markets and also the inflations. Well, with this fixed budget system, well, the problem is there is no incentive for the hospitals to actually operate more efficiently because, well, they know it regardless how many patients they treat, how many service they provide in the markets, they will always receive that fixed amount of money. So there is no incentive to actually for the hospital staff to work at a more efficient way, and there is no incentive for the administrator to actually provide a better care with less resources. Also, at the same time, there is no financial incentive to reduce costs and also to reduce waiting time, which is the biggest problems in the beverage healthcare system. Well, in 1991, the ruling's Conservative Party in the UK actually passed a set of reforms to introduce the competition between healthcare suppliers. So the reform actually introduced a regional purchasers responsible for buying the basic elective care from the public hospital for people in the regions. So these purchasers actually has a limited tax fund from the governments. But they have all the incentive to actually negotiate for a cheaper contract with the hospitals. So the lower the price, the more hospital they can actually afford to contract with and more patients they could actually afford to treat. The National Health Service also rewards those purchasers who can achieve a shorter waiting time for their consonant. Well, on the supply side, the hospital also has no incentive to actually offer this inefficient operations because they need to win those contracts with the purchaser to receive the revenues. And this buyer-seller relationship between hospitals and government purchaser was known as the NHS internal markets. So in order for the individual hospital to win the contract, of course, they need to offer a very competitive price in the market. And shorter queues will also benefit them to actually get the contract on hand. Well, since 1991 reforms also mandated the prices to be equal to average costs. The hospital needs to reduce costs in order to earn their operations budgets. So in theory, those incentives to lower costs arising from the competitions for the contract can actually induce the improvements of hospital efficiency. So with the incentive now setting into this system, well, it's very likely that the hospital will more likely to actually operate under a more efficient way. There are several evidence that suggest the waiting time decreased dramatically after the reforms. However, Popper et al. In 2008 argues that one problem with this reform is the reliable data on healthcare quality was not available. So the purchasers could observe only the hospital's price and the waiting time. But in general, they actually did not know about variables like mortality rates or other relevant clinical information. So the competition between public hospitals revolved around cost and queue length, but not on quality. So the competition may actually have motivated the hospitals to sacrifice the patient's outcome in order to achieve the cost saving and shorter waiting time. And in this phenomenon here, we call this race to the bottoms. Because it's so competitive, the hospitals in general, they would just might be sending the patient back to home and not having them to wait in line, or maybe having the service done on the patient quickly without even double checking it. So the quality, it's not observed in terms of the previous studies. So the initial experimentations with competition within the NHS actually ended in 1997, as the Labour Party actually comes into power. From 2002 to 2008, there are 3 large reforms rolled out that expand the competitions much more ambiguously than the initial experiments of internal markets. So the three initiatives of the English second wave of market-based reforms includes, number one, it moves hospital away from the global budgets to a payment by result system, which is what we call the PBR system. Also, the reform allows patients to choose between providers in the healthcare market. And last, the reform allowing hospital administrator a greater autonomy in managing their hospitals. Well, unlike the previous reform, this reform actually set a uniform price for all hospitals in the country. So that now the hospital, they cannot actually compete in prices. They can only compete with other hospitals with quality. Also, since the prices are uniform, the private and public practice basically provide the same financial incentive for doctors, so that the doctors will be less likely to neglect the public health care system or leaving the public sectors. So it expands the patient choices, meaning the hospital can compete for patients directly rather than through the intermediary purchasers. Historically, the hospital in the Beveridge model actually received the funding in the forms of budget from the government. And this budget, known as the global budget, will typically negotiate between the government and each individual hospital each year based on the previous year costs, adjusted for inflations and also change of the market. Well, the objective for this global budget payment system is to contain the healthcare costs within the public healthcare system. However, the system itself might actually create some preserved incentive for the hospital. So for example, a hospital might actually close to exhausting its budget by the end of the year. It might actually want to slow its rate of patient intake in order to avoid overspending. As a result, the hospital might actually keep inpatients in bed longer to avoid admitting new patients. More importantly, if the budgets are based on the past expenditure, then the inefficient hospital might actually get rewarded for their high costs. An efficient provider who can actually contain costs better, on the other hand, might actually effectively punished with the lower budgets reported. So in general, a system hospital of this payment system might not actually provide proper incentive for provider to improve the productivities in general. And that's the reason why it motivates many beverage nations to move away from this global budget payment system and towards the operating on an active-based basis. The payment by result program basically was introduced in the UK in 2004 to replace the global budget payment system. Its bundles of service are known as health resource groups. Well, under the health resources group payment system, the services are typically grouped based on both the patient diagnosis and actual procedure. So the resource costs of each service in the bundles are similar. The hospital will receive price associated with the bundle each time it conducts procedures within the bundle, and hospitals receive larger payments if the patients require more complicated or costly procedure. With the health resource groups, the hospital income is now partly linked to the volumes of the service provided. So the provider that care more patients receive more revenues, and also more productive and low-cost hospital actually earn more than the inefficient one. So in general, this active-based compensation actually motivates hospital to improve the efficiency, potentially also reducing costs and patient waiting time. However, the policies to implement the health resource group's payment system might actually backfire if the price of each bundle of medical services is set improperly. So for example, if the price bundle actually setting too low, which below the marginal cost for the provider to provide those services, well, the healthcare provider might actually avoid to offer those underpriced services to avoid losing money. On the other hand, the provider might actually over-offer the medical service with excessively generous remunerations. In either case, the result will be worsen the patient outcomes because, well, overuse of those services on the patients or either not having the service available for the patients will not do anything good to them. Well, despite this concern, some empirical evidence actually suggests the English Payment by Results program introduced the HRG pricing actually increased the provider efficiency in the country without sacrificing the patient's health. Well, moving to a system of payment by result tying the hospital revenues to the number of patients seen. However, the policy goal for higher quality hospitals competing to attract patients will not be succeed if the patient are not permitted to choose between hospitals, especially in the case of UK. Before the reform was introduced in the UK, well, previously, patients actually assigned the hospital by the residential location. So there is no way for hospital to compete for the patients. And this phenomenon is called the postcode lottery era. Well, in 2006, the GP under the English NHS were required to offer their patients a choice of at least 4 different providers whenever referring them to the hospital care. And by the mid-2008, patients in UK were granted free choice of any national health service provider nationwide. Well, so enabling the patient choice has the potential to improve hospital service through competitions in several ways. First, the patient choice may actually motivate the hospital to perform well in order to protect their reputations or gaining privilege of the hospital. Doctor and hospital staff, they want to be recognized as the best, and they hope to compete for patients with the hospital from the next town over. Also, opening up the patient choice improve the patient outcome if the threat of the patient switching to a better provider actually motivates the hospital to improve. But of course, in order for the patient to choose a better hospital to go, well, it has to be true that the patient can actually differentiate amongst provider and make good decisions about their healthcare. Well, Anon's NHS actually established a website called the NHS Choices. This is basically a website reports data about each hospital, including the mortality rates, history of the antibiotic resistant bacterial infections, food quality, availabilities of parkings, and review from the previous patients. So in theory, this information can actually enable patients to make improved decisions about their health care. However, one of the biggest concerns about opening up the patient choices is that the richer and better educated people might actually better able to take advantage of these choices available to them. So obviously, the better educated group of population, they may actually have a better sense of which hospital it's better and taking advantage of all this available information in the markets. So ultimately, it may create a problem of equity within the healthcare system. Allowing the patient to choose their own provider might actually reduce the waiting time and improve the hospital quality. However, it also poses a potential negative impact on equity. So this is a trade-off that the nations under the beverage system will have to face. Before the 2002 and 2007 reform, the English government centrally got the resource allocations of all the public hospitals. They will regulate the number of surgeons, the number of doctors, the number of nurses, number of beds in every single individual hospital. So the individual hospital manager, they were not given any freedoms to actually improve efficiency, even if they have any idea about how to do it. Well, the reforms in 2002 actually relaxed the government control over the operations of the public hospitals. Well, with the previous two reforms that we mentioned, allowing patient choice and the PBR payment system, now the hospital manager can actually adapt to the local market conditions and attract more patients within the different strategies. To enable even greater innovation, the government actually allowed high-performing hospital to become a new type of entity, and this is known as the foundation trust. So the foundation trusts are basically given to greater autonomies over both their operations and how they distribute their extra revenues. So the foundation trusts are similar to private hospitals, except they are audited by an independent non-government agency known as the monitor. So empirically, the question remains whether providing the public hospital with private incentive and the autonomy to act based on this incentive improve welfare. Well, empirically, most of the economists actually found the reform in 2002 to 2007 in the UK actually provide a very significant positive impact to the healthcare system. Study like Copper and All in 2011, they actually find that the reform actually reduced both the mortality rates and also lower the waiting time for the patients. But despite this encouraging evidence about hospital management, the consequences of the reform have not been always positive. For example, take a case of the Mid Staffordshires. In March 2008, the Mid Staffordshires Hospital Trust was actually promoted to Foundation Trust status, well, mainly because they can maintain the cost or contain the cost at a very low level. However, the healthcare commissions in the same year, when they review the annual reports of the public hospitals, they actually noticed that the patient mortality rate at Mid Staffordshires were actually higher than the comparable hospitals. Well, in April 2008, only a month after the Foundation Trust status was granted, the healthcare commissions actually launched a formal investigation into Mid Staffordshire's hospitals. Well, the investigations actually found that the mortality rate will actually indeed higher for emergency patients at the hospital trust. It also revealed a dangerous understaffed hospitals when the doctor was actually not available. Sometimes the untrained reception staff might actually step into the emergency room to help on the patients. Well, this creates another problems to solve under the provisions of those reforms. So how are we going to ensure the quality of the hospitals if the only objective for the hospital is to lower the cost. So the story here actually suggests quality monitoring remain very, very important in order to prevent another race to the bottoms scenarios. Coming to the conclusions to this chapter, recall the three elements of the health policy trilemma that we first described in chapter 15. All policies in health always trying to achieve these three goals: health, wealth, and equity. In the Beveridge models, nations always put the focus on equity. The Beveridge nations always promote social solidarity by guaranteeing the citizens need not to worry about how rich they are if they are sick. However, the increasing concern about the long cures, the inflated public healthcare expenditures, forces the Beveridge nations to actually adopt into different types of policy or going through different reforms. Well, I would say the reforms that we've seen in UK, it's only the start. There will probably more to come in order to improve the efficiency of the healthcare system. The ultimate goals of all this reform is to improve the patient outcomes and also control costs more effectively within the hospitals or healthcare system, and at the same time without harming the equity. In the next two chapters, we are going to take a look at the Bismarck system and the American system separately. By comparing the three systems at the end of the section, hopefully students will get a better sense of how complicated the healthcare economics is to the different nations. So I will see you next time.